And then I open this academic ceremony in which Carlotta Gamberini will defend the academic thesis called Microorganisms, Maternal Health and Healthcare, a multidimensional study of microorganisms' role in women's reproductive health and healthcare. Before we go to the defense, I would like to introduce at least the supervisory team, because otherwise nobody knows who they are. And of course, they're very important, and that is Dr. Elena Ambrosino. She's an associate professor in the Institute of Public Health Genomics of our university. And on her side is Professor Servaas Moret, and he's a professor in host pathogen genomics and public health in the same institute. And then there's the co-supervisor, Dr. Salwan Al-Nasiri, and he's an assistant professor in the Department of Obstetrics and Gynecology, also at our university and medical center. The other ones sitting here, I will introduce when it's their time to ask a question. And my name is Nanne de Vries. I'm an emeritus professor and replacing the rector today. And now, before we go to the defense, I would ask you to give a presentation of your work in about 15 minutes.
Thank you very much. Esteemed prorector, esteemed opponents, dear supervisor, family and friends and colleagues, thank you very much for being here today. I'm honored to share with you an exploration presentation of my doctoral research, which delved into the intricate landscape of maternal health, while also examining its complex interaction with microorganisms. The overarching objective of my research was to explore the profound influence that microorganisms have on maternal health and healthcare in the world. Crucially, as you can see here from my outline, this thesis adopted a comprehensive approach because we recognize that it's imperative to investigate both the biological and also the social factors that influence maternal health and healthcare. In fact, in today's interconnected world where global health challenges are increasingly complex, I think adopting an all-inclusive and multifaceted and interdisciplinary approach, I think it's imperative. Because health disparities and maternal health outcomes are often, as we can also see here, influenced by many factors that span from genetic predisposition to social and economic and environmental factors, so from social determinants to more biological determinants, which are all interconnected as well. Because, unfortunately, the stark reality does remain that maternal mortality is still really high around the globe. In fact, in 2020, 700,000 women died, and as we can also see here, where the red is darker, 95% of these deaths, which are preventable with better antenatal care services, happen, as we can see, in the global south. And the multifaceted aspect of my thesis, I think, is also reflected in my methodology. In fact, I integrated a mixed methodology with both quantitative methods and qualitative ones, I think adding a layers of richness to my research. In fact, by combining quantitative data, for example, on the role that STIs have on maternal health outcome and clinical outcomes, and qualitative insights, for example, on the impact of infectious disease on antenatal care, I think I could have a better comprehension and a more holistic view on the issue. For example, the alarming statistic that we saw in the map before. The importance of, I think, also this complex approach becomes really evident also as we dive into the landscape of genital infection and maternal health. In fact, where I think, again, here it's crucial to underscore and highlight the impact that infectious disease have on maternal health issues, maternal health outcomes all around the world. In my project, I decided to focus on sexually transmitted infections, or STIs, and I explored their interaction with maternal health and maternal health outcome from a more here biomedical perspective. Throughout 2 comprehensive systematic reviews, one in Sub-Saharan Africa and the other one in Latin American countries, I tried to investigate the impact that mainly non-viral sexually transmitted infection, namely chlamydia, gonorrhea, trichomoniasis, and syphilis have on clinical pregnancy outcomes. And from the review of this literature, I uncover, first of all, considerable variability between different regions, but also we could link these STIs with many adverse pregnancy clinical outcomes like preterm birth, stillbirth, low birth weight, and unfortunately also neonatal death. Moreover, my work also addressed a crucial gap by also addressing the persistence and the burden of these non-viral STIs on a cohort of pregnant women living in Pemba Island in Tanzania. And within this cohort, we did observe a progression of STIs prevalence, point prevalence, between pregnancy when we tested them and after pregnancy. As we can see here, it increased from 12.7% during pregnancy to 16.5% after delivery. What we also saw is a high persistent rate of chlamydia, trachomatis, and trichomonas vaginalis. Chlamydia, as we can see, 81% of cases persisted for up to 13 weeks, similarly with trichomonas vaginalis. And to add to all these issues, this population, this cohort also suffered the burden of co-infection. And I think the evidence from this study does underscore some shortcomings of diagnostic and management of these infections, mainly in research-limited settings, like we saw in Sub-Saharan Africa and Latin American Caribbean countries. But I think from these results, what becomes clear is that we need more STI surveillance data in order to also have and develop better strategies to help with these issues of STIs. I think then the complex landscape that we just saw of infectious disease surveillance and diagnostic unveils larger challenges that spans continent and context. In fact, as we transition now from the complexity of infectious diseases during pregnancy, my work spans the challenges and the broad domain of maternal health care. What we saw is that addressing these challenges also, we need to recognize and overcome another group of challenges. And also here, they can be structural, they can be biological, or also institutional. To name a few, the struggle to reach healthcare facilities, the economic disparities that are rooted also in poverty, the insufficient healthcare infrastructure, they all act as a deterrent, discouraging women to seek antenatal care in many of these settings, not only in the global south or low and middle income countries, but also my research span different geographical locations like high-income countries. There are many solutions and innovations that we can talk about, but here I decided to bring 3 that I believe they should be high on the agenda of many policymakers all around the world. Firstly, the establishment of a universally accessible and free antenatal care for all should be on the top of everyone's agenda, policymakers, healthcare providers, governments as well. And I think many of the providers that we spoke to and the results from my work highlight the importance of these antenatal care that can be accessible for everyone. Secondly, I believe the enhanced provision of health promotion and education through many targeted initiatives is another essential part of antenatal care that can help everyone, women, individuals, their families, and community to have also a better view on the importance of antenatal care. And lastly, I believe the empowerment of individuals, their families, communities is another essential part in order to improve antenatal care and also improve the health of women and their children. As we progress now on the continuum of care, we reach a pivotal point, the point of prescribing and treat this infection. And also here, we talk a lot about challenges, but we also find many challenges here that span diagnostic challenges and physiological ones. In fact, coming back to resource-limited settings, there can be not only there, but there's a heightened challenge of diagnostic. In fact, limited infrastructure, limited access to testing can bring a lot of challenges and can also bring the misdiagnosed or the undiagnosed infectious disease, like we saw before. They can have a detrimental effect on the health of mothers and their children. Coupled with the diagnostic challenge, we also find physiological challenges. In fact, we know that pregnant women, during this critical point, the immune system changes, and while there's not a lot of evidence that's showing that the immune system completely shuts down, there is evidence that pregnant people have a higher chance of contracting infectious disease, and these challenges together, they bring together challenges to the prescribing, the accurate prescribing of antibiotics. And to address these challenges and also explore for possible solution, we decided to do some, again, reviews of the literature and also some qualitative studies where we could directly speak to the providers. And what we found is that antibiotic use during pregnancy, we saw that in the last few years there was an increase, and 80% of the drugs that are prescribed to pregnant women are antibiotics. However, what we saw in the literature and what we also saw speaking with the providers, there is also a scarcity of evidence-based knowledge that can be used to prescribe antibiotics to the pregnant population. And many prescribers, and from literature, what we found is that there is really this need for providers to have a better understanding of which antibiotic they could use. To finish, we also wanted to expand the scope of my investigation and my research beyond maternal health. And so we delve into the unique perspective of antibiotic use practices and prescribing of antibiotic use, this time in dairy farm in Belgium and the Netherlands. And with this study, we wanted to show how the intricate dynamics that connect human health, animal health, and environmental health, they should all be taken into account while considering solution or while investigating these issues. In fact, the One Health policy and philosophy advocates for a more comprehensive and holistic approach to healthcare. And with this study, we wanted to show that many of these challenges that I talked about until now are all interconnected. As I finish this presentation, I wanted to give a few take-home messages that I took from the work that I did until now. I believe that, like I said until the beginning, having a holistic and more comprehensive investigation of these issues, I think, is the only way in order to find better solution for all. Secondly, I think the setting of a universally accessible, patient-centered, and free antenatal care for all is of utmost importance to have better maternal health and neonatal health outcomes. After that, I think, like we saw with the last chapter, it is important to have a united front and a more interdisciplinary approach when studying these issues, because we saw that they're all interconnected. And lastly, like I just said, the global cooperation and a comprehensive and holistic view, bird view on this issue, I think can be one of the only chance that we have to lower the maternal mortality all around the world and have better health outcomes for everyone. So thank you very much for your attention. Now I give the word to the Reproductor. Thank you.
Thank you very much for this clear presentation. Actually, I forgot to also introduce your paradigms, and they are important too. I saw the one, Pierre Thomas, nodding all the time encouragingly, although you didn't see it because it was in your back. And Denise Slent is also here. Okay, the first question will be asked by Professor Dr. Milena Pavlova. She was the chair of your assessment committee, and she's a professor in health economics and equity at our own university.
Dear candidate, my congratulations to you and your supervisors for this very important dissertation. You have investigated a very important topic that is related to women's health, and women's health is a key policy issue, key issue in research, and also an important issue in society around the world. So it's a global problem. Evidence that you provide in your dissertation, I'm sure they can inform decision makers on how to improve women's health and how to address it from the perspective of maternal health, neonatal health, sexual transmitted infections, antimicrobial resistance, which are all topics of the chapters in your dissertation. I agree that a comprehensive approach that you have is very important in order to investigate problems such as reproductive health and maternal care. Your dissertation is very much welcome. I must say that my first impression of your dissertation was that it's a very huge piece of work. This is not something that you see very often, and it's really impressive. You have presented many insightful studies, and also they are published in respectful journals. And I'll be happy to discuss your dissertation referring to several chapters. So the first two chapters are review chapters, and they focus on associations. And you also have another empirical chapter which also refers to associations. Now, if you really want to address a problem, you need to know the causes. And studying association is an easy way to do research, but has certain limitations. So I was wondering, what was the motivation? Why did you choose to focus on associations and not on causality, especially in the review studies? Could you please explain the motivation?
Highly esteemed opponent, thank you very much for your question and your kind words. Yes, we decided to start with this study of literature on dissociation. Like you said, it seems that it's easier. I think because we want this to be the fourth stepping stone to have also to study the beyond the association, but also the causation. As I showed at the beginning, many of these settings, they do have a lot of factors that come into play, which I think make the research of the causation harder to find. So the association study was the first stepping stone in the process to also, for future research, to also study the causation. I think it should be, the study of the causation should not only be made with the literature and study of literature, but also the study, more qualitative study or also quantitative data within the territories and the settings. But I believe that the next step of this research should be studying the causation, also looking at the different factors that can come from the biological factors, like we said, but also the institutional and the social, the community and environmental factors that can be at play. There are many variables, and yes, I do believe that there should be also then the study of the causation between the
this
two.
very well links to my next question.
Yes.
So if the results of the reviews presenting associations, maybe some of those factors, or maybe other factors that you studied in your dissertation are the causes. So according to you, what are the actual causes of adverse maternal health?
Yes, I think I want to start from, first of all, the institutional level causes. Many of these settings, they lack the infrastructure. They lack the antenatal care infrastructure that are needed for women, their families, and their communities to seek the care. So I think to have better infrastructure and also better diagnostic services should be of utmost importance. So maybe the causes of lack of adequate antenatal care do come also from lack of infrastructures. I think also the I said as well the lack of education around the importance of antenatal care and seeking antenatal care. Many of these women from literature, we do see that they do not reach the healthcare facilities because of all the infrastructure, transportation as well. Most of the time, there are no streets, or they don't have the money. They are the primary family helper in the house. The women, most of them, also because of cultural and traditional values, most of the time they stay home. In a lot of these settings, they don't have access also to, for example, money, and a lot of the time also to education, so also these type of settings, and maybe also biological. Again, these women, because of traditional values and cultural barriers sometimes, and also I think the view that that maybe healthcare providers can have, this is a bit far, but like in the antibiotic study, prescribing practice that we study, we did see there is a difference, in a gender difference of the antibiotic prescription. So I think also that plays a role, the fact that a lot of the time maybe women, they're not believed, they're not listened enough, and this all together I think it brings to the low attendance of antenatal care and also the high maternal mortality and morbidity that we can see.
Okay, so imagine you have a very big research grant and you have the possibility to continue your research and specifically to study causal effects, hypotheses that are associated with causes. How do you see, what kind of research you think you could do to study causal effects that you just described?
Okay, yes. I think maybe research on the ground, more a bottom-up approach, where you can, find obviously the community. I can also take the example, the Pemba Island community in Tanzania, a more study of, first of all, to see what are the real causes of, low accessibility or low attendance of antenatal care. I think a more qualitative approach can help here in order to find what are the real causes. So interviews with women, or a lot of the times maybe the community leaders of the community. It can help to start understanding. Also interviews with healthcare providers, nurses, midwife. There are the first people that that meet these women, their families, and the individuals that try to seek antenatal care. After that, I think it's important to maybe also do, my understanding, do a more a work with the policymaker and governmental officials that can maybe do the big changes to bring the research that I could see on the ground to who can, I think, make the difference with policy changes and intervention there.
Okay, maybe very briefly, quantitative research, would you consider?
I think also quantitative. I think maybe we can couple it with, I did infectious disease and STIs treatment. I think coupling, like I did here, a mixed methodologies where we can see also the biological factors can also help to seek better interventions.
Okay, thank you very much for this discussion. I give the word back to the prorector.
Thank you very much, Professor Pavlova. I now turn to Professor Anja Krumer, and she's a professor in global health of Maastricht University.
Dear candidate, a lot of congratulations with your enormous, impressive work. Multidimensional, holistic, and we are, I think, in dire need of that more transdisciplinary approach to the complex problems that we face. But of course, it's my task to question you also a little bit. And I would like to start with Chapter 5 and Chapter 10. Chapter 5 is about antenatal care for women in resource-poor settings. And Chapter 10 is about practices with regard to the prescription of antibiotics during pregnancy. Both of your chapters focus very much on local reproductive healthcare systems and how they should function and how they should be more accessible. And also the model that you use for the WHO model that you use is very much focusing on national settings, local settings. And I was wondering whether this, how this links to the fact that in both chapters, the experts that you spoke to were experts that were mostly representing biomedical, people with a biomedical background, and actually even people from high-income countries. And is this focus on what is going wrong over there, is that not a particular gaze? Is that not a particular way of looking at problems? And if you look at it from a biomedical, European high-income country perspective, aren't you then silencing all kind of more structural global processes that cause inequality and problems with resources? And I can imagine your book is already this big that you didn't have much time. But if you had more time, even after today, would you consider focusing on those aspects as well? And how would you like to do that?
Highly esteemed opponent, thank you very much for your question and your kind words. Yes, I think this is one of the, we can say, limitation of part of my work, both the exploration of solution and the antibiotic prescribing practice. The qualitative study was done mainly in this neighboring country, Netherlands, Germany, and Belgium. And the solution with the expert consultation of the solution of antenatal care was also done mainly with experts from all around the world, but from high-income countries. There were just few, not many, from the global south. I do believe, like you said, it's very important. I didn't have much time, as you also mentioned, to also try to investigate that part, but I do think it's an essential part, especially if I am talking about issues and also solution as a setting the global south. One of the scoping review, the global survey that we did see a bit more respondents from the global south, but not enough. I think there are also many issues there. I think the voices of people and communities, individuals that are, boots on the ground in this setting should be listened to and should be acknowledged. And I do think, again, further research should be done while also taking into account these voices that are really important. I think also here, for example, the expert consultation, if I think about, a second expert consultation that we can be doing, I think having more voices from the Global South is really important. If I'm not mistaken, there were just a few. Also, for the antibiotic prescribing practices, the qualitative studies with interviews, short interviews that we did in Belgium, Germany, and the Netherlands, I think we can have a similar study also in many of the settings that we studied in the, maybe again, starting from Pemba and other sub-Saharan African countries. So thank you very much for your, again, words and question. I think it should be the next step for our research.
Thank you. I was wondering why did you focus? I mean, it's a very complex and rich field that you've been studying. Why did you focus on One Health, for instance, and not on other aspects. What is the rationality behind that? Because it's, of course, associated, but there are many things associated. And why in Belgium and the Netherlands?
Yes. So I think with COVID, we did see much more that microorganisms, they travel really fast within borders. So choosing Belgium, Netherlands, and Germany for us, or Belgium and the Netherlands, was to also see, first of all, how the challenges and how the prescribing works in both countries, because there are neighboring countries, but we did see variation in the two. We decided to focus also on the One Health approach, because when we found, from what we found from our research of the antibiotic prescribing practices, we did see that antibiotic resistance was a bit of a buzzword, and one of the main challenges that also the prescriber and the literature show of one of the next challenges in antibiotic prescription, but not only in humans. So I think this was our rationale behind that. If we want to really find a solution and try to tackle the challenge of resistance in humans, here we see, for example, in the pregnant population, we also need to have a more holistic approach to it. So that's why we decided to also look at the animal setting, again, only in these neighboring countries, but it's, I think, food for future research as well.
Okay, thank you. I have another question. Chapter 7 is about, I still have some time, yeah. Chapter 7 is about this innovative approach in the UK.
Yes.
And that is an approach particularly for migrant and refugee women. And I was wondering, again there you spoke mostly to the midwives, hardly to the women themselves. And a lot of women will not end up even in those services, even though they might be better than the others. Do you think you would have gotten different and other information had you spoken to those women? And the results of what you did now, but also had you spoken to those women, would those results be applicable, because it's in the UK, would that be applicable to women in low-income countries? Would they be applicable to all women, also in high-income countries? What's your thoughts about that?
Yes, so we did interview only midwives, because we decided to choose this interdisciplinary team as well, where midwives and nurses are the first respondents in this clinic. I do think that maybe also interviewing, again, for future research, other healthcare providers or providers that do not have the direct contact sometimes with the pregnant population can be helpful as well. And so also what we show in this study is that vulnerability is not just, we cannot give a definition to what vulnerability is. So this was applicable to the settings in the UK, where there is, a nationalized health service, where it's freely accessible most of the times. So I think that in part we can take these results and also transport them in the Global South or in other settings. But again, I do believe that the vulnerability is associated with a lot of factors where you live and the environmental institutional factors. So I think in order to have a better view of the vulnerable population in resource-limited settings, I think a different study should be made for that setting specifically.
Okay, thank you.
Thank you.
I have one last question.
Yes.
I think
Short question. Yes,
short
please.
question. What I see is that you did a lot of different topics. You covered a lot of different topics in a lot of different countries. Is there a reason why you did not systematically compare all those countries and all those topics?
Yes, there is no reason. I think maybe the reason was a bit the lack of time, because there was a lot to do, and I think, again, much more work that we can do, but the suggestion, I think it's really good to have also an analysis of the difference and the challenges in between and within countries.
Okay, thank you.
Thank you.
Thank you. For the next question, I'm happy to announce guests from outside. We're always very happy when there are guests from outside because it attests to the importance of the work that has been done, of course. So I'm happy to see Professor Ank de Jonge. She's a professor of midwifery science of the Free University and, of course, in the Amsterdam Medical Center.
Thank you very much. Dear candidates, first of all, I also would like to congratulate you and your team on this very elaborate work. Consists of 10 well-described studies, and it's a very impressive piece of work. Congratulations. I would like to discuss with you on chapter 6, where you describe about COVID, the COVID pandemic. Now, we've almost forgotten it, but how many restrictions were imposed on our society during the pandemic, and luckily it's now behind us. But however cruel COVID has been, it has also provided a natural experiment in which we tested tremendous changes in society and healthcare that we otherwise would never have implemented. So we can learn a lot from that, and you showed that too. So in this chapter, you interviewed midwives and obstetricians about changes in antenatal care during the pandemic. So my first question, you mentioned a few of the changes that were made. Of all of these changes, which one do you think had the most impact on women, pregnant women?
Highly esteemed opponent, thank you very much for your words and your question. I think one of the aspects that was much more harder on both, I think, the pregnant population and the healthcare providers was the telemedicine and the video calling and the use of, the virtual consultation. I think this was for few different reasons. First of all, from the healthcare perspective, I think what was hard is that they were not able to because just through a video you cannot see, for example, what we can call the nonverbal feedback that sometimes you can see and you can assess while you can see the person in front of you. So I think that was really hard on both the providers, but also from what we understood interviewing the providers, also the women and their families. There was a lot of fear also connected with the pandemic, the fear of contracting the virus at first when we didn't know a lot of what were the effects as well of this virus on the mother and on the baby. But I think the telecommunication was, again, I want to go back to that because I think also highlighted a lot of issues and a lot of disparities between women. In fact, the possibility that not every woman would have access, for example, to Wi-Fi, broadband, or even a phone or a computer, I think that showed a lot of the disparities between the population.
Yeah, I agree. Yeah. This was an important one, but I'm actually surprised you mentioned it as the first one because I think, as you described too, and which we found also in our research, is that there are sort of mixed feelings about this. That there were also some positive aspects of being able to use telecom.
I think that was what we heard from the providers is that the positive is to implement it more. I think what the problem was that from almost one day to the other, they had to close. The visitation would had to, almost half-ten. So I think the fact that they were both they were not prepared for this. I think that was an issue, but also can bring a lot of also positive aspects.
Yeah, it's also an innovation that accelerated greatly through COVID, I think.
For what we understand is that it can be an innovation, but it needs to be done in a way where everyone can also have the access to this technology.
But I'm a bit surprised, although you do mention it in your chapter, that you don't come up with the role of the partner of women.
Also, yes, true. Yeah, the role of which I think goes back a bit with the telecommunication, because what we heard from some providers is that it was harder for them to, for example, assess if the women were also victim of domestic violence. I think that couple, right, like if you don't really see it, or a lot of the time when the women can come to the clinic, they could also, come alone without the partner and tell them, the issue that they have at home in front of a computer. They could not done that because the partner was in the, or also
So you now emphasize the negative role of the partner, really, but I was thinking of the positive one.
Okay.
In the sense that it's actually
Yes.
what we found also is what is actually strange is that we're trying very hard to involve partners in pregnancy, saying that it's not just the thing for the woman, but usually he, sometimes she, should play the role as well.
Yeah.
And then as soon as a pandemic hits, we say, well, actually, you're not that important, so you can stay at home.
Yeah, no,
That was a big thing.
There was also a lot of anger. They said a lot of anger, a lot of frustration because they could not. Yes, I said the negative, but there are positive for sure. The being able also I think for the woman was really important to have a lot of time if they have other children, partners, and family members to come and experience also this, which should be like a joyful occasion for everyone together. Yes.
So, God forbid, and I hope not, but if we ever were to have a pandemic again, do you think we would make the same changes that we did this time in antenatal care, or are there things we would do differently next time?
So I want to be positive here and think that the pandemic did change our view on the importance, first of all healthcare services, but also antenatal care, because we saw during COVID pregnancy, they didn't stop during this time. I hope that who can make the changes, governmental bodies, provincial bodies, they can also put the money where the providers needed the most. What a lot of them told us is that for example, the PPE shortage, the high workload, because a lot of them, at first we didn't have the fast testing, the point of care testing as well. So hopefully we do have best practices for the future. I really hope so.
Yeah, that's in terms of resources, and I agree.
Yeah.
We've seen that the hospitals often took the priority.
Yes.
So maybe we make different changes there, but also as professionals, we implemented many restrictions out of fear of the infection, of course. Are there restrictions we would do differently next time?
I'm talking about the partners. Maybe that could be something that we can see. We saw right now with masks and appropriate protective equipment. I think now we know that we can still be in the same room. Maybe not the entire family, but being able to have at least a support system there. I think that would be important, and maybe the improvement of also the technological issues as well.
Yeah, I think we've improved on that a lot. But I think the partner really came out, I think, on many studies that I think we would not be as strict next time.
Yes,
I think that
hopefully.
has caused a lot of harm.
Yeah.
I agree with that. Yeah, I think my time is almost up. Just one quick question, maybe, that we talked about negative things that we did. Are there things that we learned in the COVID? You talked a bit about telehealth, maybe other things that we learned in the pandemic that we think actually we should use it still to improve maternity care as it is today?
I think what's most important is to understand the crucial role the healthcare providers have in taking care of the pregnant population and their families. Like I said, I mentioned before, the high workload and the fact that a lot of the healthcare providers had to be sent, for example, to different other departments to help. I think that I like the importance of collaboration also within departments and within different healthcare providers, and the fact that when maybe the capacity is not there, there is other providers in the hospital and the clinics that can help, and the collaboration between the different departments. I think that is really important.
Collaboration, we should continue with good collaboration.
Yeah.
That's always a good one.
Yes.
So other ones I'm going to discuss with you in the future, but I think for now I'm quite happy and give back the word to the director. Thank you.
Thank you very much. I now turn to Dr. Ron van Golde, and he's an assistant professor, but also the head of the Division of Reproductive Medicine at Maastricht University Medical Center.
Thank you, dear candidates. Congratulations. It is an important and interesting work. I also want to congratulate your supervisory team. First, I would like to start off with your goal. So the highest number of maternal mortality is around 1%. What should it be in 10 years?
less than 0.5. No, I think we need to strive to lower the maternal mortality everywhere. We saw it in the map in our countries, in the global north. I think it's a good goal for many of the, like we saw, the darker red countries where maternal mortality is still unacceptably high. So I think lowering to the different standards also that we have in the global north, I think that should be, it's also one of the SDGs to try to lower below a threshold.
Yeah. I can imagine, but just a little bit more from a philosophical point of view, why do you think we should, what's the reason you think it should be that percentage?
I think, again, I also will try to answer it from a philosophical point of view. I think that the health of mothers and their children is not really high on the agenda of a lot of policymakers around the world. And we fail, I think, to see the importance that healthy mothers and healthy children can have, the impact that they can have on our economies, on our environment, and our society as a whole. So I think thinking like this, like we mothers and children, most of all, are the future for this world, for our society. So I think thinking as an investment for everyone's society for the future, I think that should be, again, high on the priority, on the agenda of many countries from all around the world.
Mm-hmm. And you already mentioned in your presentation, and a couple of questions about it, of course. But let's say that in a couple of months, one of your supervisors is going to call you because she's working at the WHO, and she has been asked what should be our next step in accomplishing these goals. So what would you focus on, and please elaborate on why, and why you think that's the best step. Mm-hmm.
So I think if I think about the continuum of care, the first step would be the diagnostics. Like I said before, in many of these settings, in resource-limited settings, there is a lack of infrastructure, of diagnostic infrastructure. There are connected with many other issues. There are not enough resources. There are not also enough healthcare providers or workers that are trained to do these diagnostics. Mm-hmm. So I think that better access, also to then have better, for example, surveillance data in order to then have also better, better solutions.
I'm going to interrupt you.
Yeah.
So one would say that's very obvious. Mm-hmm. Why didn't we focus on that before? In chapter 5, you have this holistic approach, mm-hmm. And I think, at least for decades, people are trying to train people in health care. Didn't we do that before, and why we are still looking at these high figures?
I think, yes, it was done before, but maybe not as effectively as it should be done. Again, I think there is a need of more resources that are allocated. Here,
is it money?
Is
it money? So when we put...
I think it can also be money. That there are many issues. So money can be one of the factors that. Again, maybe, like I said, is the fact that women's issues, the women problems are not high in the agenda for many governments and many societies. Mm-hmm. Going back, for example, in the diagnostic, I think right now we are seeing an increase of, for example, the use of point-of-care testing, which can, I think, go around the issue of money. If there are not enough money to have, these labs, for example, that we have here, where we can do molecular testing, fast molecular testing, I think there should be, for example, an increase of resources to have better research on and finding better point-of-care testing, which can be used in these settings, mm-hmm. without the need of big labs, without the need of also trained personnel that can do the test.
Yeah, when you because you focus, for instance, on Pemba, this in Tanzania, would that be the way to go there? like you described now?
Yes, I think what they did in Tanzania, this biobank where we can put all the samples that we have, that we can then monitor also the situation. I think that is an example that can also be, we can also bring it to other settings. So having this type of biobanks that can also give us where it's harder, I think, to have bigger infrastructures and we don't have a lot of resources. I think this example, again, can be used for other settings in order to have, I think, like we said, this surveillance data that then can be used to have better policies for the communities.
Yeah. I could imagine that would be also a kind of research project. I'm not an expert, for instance, in the global health or investing in certain countries which you want to improve. But the general impression you have is when you remake ideas, maybe ideas like mentioned before in our Western countries, is not going to bring you to the goal I ask you for. So could you think of other policies? Should be more focused on local governments, local institutions, and what should be done there?
I think, going back to what I said also in my presentation, maybe the empowerment of the population can also be a crucial step to have better maternal health outcomes in the future as well. So empowerment through, a better health literacy, for not only women, their families, their communities, to have a more holistic view on the importance of this this care, which I think empowering women in the communities can have an effect then also on a bigger effect on societies and governments as well.
I think there's a good way. I just recently saw a documentary on the BBC which had women as an ambassador who had birth complications, and that was something which worked very, very good. So I thank you for your answers, I give the word back to the rector.
Thank you very much.
Indeed, thank you, Dr. van Golden. I now turn to another guest from, far away, at least in snow conditions. It's always far away, of course, and it's Dr. Stefan Verwey. And he's a fellow in pulmonology and infectious diseases in St. Antonius Hospital in Nieuwegein.
Thank you. Dear candidates, I also want to congratulate you with this impressive thesis you wrote. Not only on the content, it's impressive, but also on the weight of the thesis. It's very heavy. I also want to congratulate your supervisory team and, of course, also your family and friends who, in their way, made it possible for you to defend your thesis here. As you know, I am a pulmonologist, but I studied chlamydial infection extensively in the past, and I think it still is a very interesting bug. And I also have a molecular background, and in that sense, I would like to discuss chapter 4 with you. In this chapter, you aim to determine the natural course of infection for chlamydia trachomatis, Neisseria gonorrhea, and Trichomonas vaginalis in pregnant women on Pemba Island, Tanzania, by detecting DNA of these pathogens in biobanked vaginal swabs collected on different time points during and after pregnancy. And you observed, and you showed that in your presentation, that for chlamydia, 81% of the infections persisted with an average of 8 weeks. And for Trichomonas vaginalis, it persisted with an average of 9 weeks during pregnancy in 53% of the cases. Would you think that mere detection of DNA without self-reported symptoms is a sign of ongoing infection, or is it the result of a highly sensitive PCR?
Yes. So, esteemed opponent, thank you very much for your question and your words. So yeah, this is a really great question, and I do not believe that it's only the positive infection and the active infection. In fact, As we know, the fact that you detect DNA and also the use of really sensitive and sensible PCR techniques does not mean that there is an active infection. It could also be other particles that are still around, also because of your immune system that clears, but also antibiotic use. And as we also wrote here, antibiotic use was self-reported by the women. So again, it's reliable, but we don't know how much antibiotics, and who maybe someone didn't tell that they were getting antibiotics, so we are not sure. So in order to be sure, we would have also detected RNA, which is what can also show active infection. Another thing that is a limitation, and we could have also done. We are not sure if this persistence that we can see, for example, during delivery or during pregnancy and after delivery, is of reinfection. We should have also done use different methodologies there to study. For example, we didn't test the partners, so we are also not completely sure if there was a reinfection with the partner as well.
No.
Yeah.
And can you think of another test you could have done on these samples to establish whether or not it could be a reinfection?
Maybe a serovar determination.
Yeah, for example.
Yeah, in order to really see if there was a reinfection or there's, no. I think that's a great thing that we should have done, and maybe again for future research, because we still have the sample. So
I agree.
Yeah.
Thank you. So this study is obviously important for regional healthcare workers and policymakers to improve maternal health. The prevalence of 2 out of the 3 sexually transmitted infections is remarkable. And with the knowledge that these infections can cause serious complications, necessitates well-organized programs. How would you implement the knowledge you acquired of this study in these kinds of resource-poor areas?
Yeah, so I think I want to connect what I was saying before. I think because of the infrastructures that sometimes are lacking in this area, I think, first of all, I think it's important to have better surveillance. So better testing as well. Or the idea of testing pregnant women in these settings to see can be, maybe it's not cost effective, but I think it can be important, because as we saw there, the association with the adverse pregnancy outcomes can also be detrimental. So the testing, and in order for the testing to be more cost effective, I think the implementation of point of care testing that can be easily accessible, affordable, and also fast can also be really helpful and crucial in these settings.
Yeah, because how feasible is this? Who is going to pay the bill?
Yes, I think that's the other main issue. The WHO definition of point of care testing, one of the main definitions is that it should be cheap. So I think instead of having this big labs with innovative technologies, I think a cheaper version, a point of care testing, can also be cheaper to buy as well. Yeah.
The international guidelines published in 2021 by the CDC recommends treatment for pregnant women with a urogenital chlamydia trachomatis infection with a single dose of 1 gram azithromycin, for gonorrhea with 500 milligrams ceftriaxone intramuscularly for 1 dose, and trichomonas with metronidazole for 7 days. All these drugs are safe to use during pregnancy, are relatively cheap, and what do you think? Do you think that mass drug administration of these medication is would increase maternal health in this population?
I do not completely agree with this. I don't think that the mass administration of antibiotics is the correct solution. We spoke before as well of the increasing threat of antimicrobial resistance. And also in many of these settings like Sub-Saharan Africa, they use syndromic management. So they do not do testing. They see the different symptoms and then they decide what is the course of the antibiotic. So I do not think that mass administration is a good solution. I think what can be done is, again, because of the risk of increasingly, resistance bacteria, I think what can be implemented is the testing of many of these bacterial or non-viral STIs during, for example, first and second trimester. I think that can be a better solution than just give antibiotics and this treatment to everyone.
Yeah, so azithromycin, for example, it's a very broad drug. You say it's not a good idea to give everybody in Pamba Islands 1 gram of azithromycin because then the whole chlamydia problem is gone. Or that's not what you agree?
I think it's because this mass use of antibiotics, I think, can only worsen the issue of antimicrobial resistance. So, and I think it's also, if we think about the effect that, for example, antibiotics have on the microbial communities of women and also children, I think that can also have detrimental effect in the long run. In fact, like a dysbiotic microbiota has been associated with high obesity and also high rates of diabetes in children in the long run.
Well, just in time. Thank you very much. And thank you, Dr. Verwey, of course, for your contribution. Carlotta Gamberini, this means that the time for defense of your thesis has now passed. And that implies that we will now withdraw and discuss the quality of the defense you just did. I would ask you and your company to await the results of our deliberations here in this room, and we will return then, and thereby I adjourn.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. I know what's on the line. I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and not. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and not. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Ooh, it's just a thesis. Carlotta Gamberini, the degree committee here present, has assessed the quality of your thesis and of the defense you just did, and in view of its positive verdict, and in view of earlier qualifications you've acquired, the degree committee has decided to grant you the degree of doctor, and this implies that Dr. Ambrosino is authorized to confer upon you this academic distinction in accordance with Dutch university custom. So I invite your supervisor to take the floor.
All right, please.
Yes, thank you. All right. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Carlotta Gamberini, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Now a few words. Dear Dr. Gamberini, dear Carlotta, I'm delighted to be here, congratulating you for today's accomplishment. Let me also extend my heartfelt congratulations to the rest of the supervision team, to your mother, your sister, the rest of your family and friends here and connected online. I stand before you and before the audience with immense pride and joy as we celebrate the culmination of years of dedication, hard work, and intellectual pursuit. It has been a privilege guiding and working with you, and I'm honored to be able to address you on this special occasion. Today marks a significant milestone in your academic journey, and I want to acknowledge the passion, resilience, and intellectual curiosity that has brought you to this point. Completing a PhD trajectory is no small achievement. It requires not only intelligence, but also perseverance, creativity, and an unwavering commitment to the pursuit of knowledge. Carlotta, I've got to know you while you were a master's student in global health at Maastricht University. By that time, you had already acquired a bachelor in biomedical sciences from the same university, and your intrinsic interest in and awareness of global issues motivated you to enroll in the Global Health Master. Along the course of the study, you first had the chance to harness the knowledge you had gained during your bachelor more broadly, and for the benefit of health across different populations and geographical regions. From then on, you continued to expand on this interest for global issues along your PhD work, which you embarked on with a heart full of curiosity and a mind teeming with potential. Your work is the result of a unique combination of perspectives, multiple disciplines, and methodological approaches. As such, it has been challenging, but also inspiring and never repetitive. You have managed these multiple layers of complexity with enthusiasm and dedication. Multiple times you have been able to convey the focus of your work, its multidisciplinary nature, and the relevance of such an approach with clarity to diverse audiences. This has been no small feat. Reflecting on the journey we've traveled together, I witnessed a remarkable transformation from an uncertain student to a scholar who exceeded every expectation placed upon you. I vividly recall the early days when self-doubt and imposter syndrome cast a shadow on your abilities. Yet, at each point, you never pulled back, nor declined a chance to step outside your comfort zone and prove yourself. embracing challenges as opportunities for growth. And you did it over and over. Every time I suggested you take on another project, contribute to another collaborative effort, coach students, write funding requests, and present your work. You never said no. You faced uncertainties with a quiet determination that gradually blossomed into self-confidence. You sought guidance, asked for feedback, and utilized setbacks as stepping stones towards personal and academic development. What emerged is not just a researcher, but a confident and empowered person, ready to push the boundaries of your field. It is this resilience that has shaped you into the formidable scholar standing before us today. As a supervisor, witnessing this transformation has been an immense source of pride. It is a testament to the transformative power of education and the boundless potential that lies within each of us. Carlotta, thank you for showing that courage, resilience, and the commitment to personal growth can lead to such achievements. Like many other PhD graduates, you faced the rigors of academic pursuit. But unlike others, you also navigated through family struggle and profound loss. In the face of adversity, you displayed an unparalleled strength of character. You carried the weight of personal challenges with grace and resilience. Transforming your pain into motivation, your grief into determination, and your challenges into a driving force to excel. You demonstrated that pursuit of knowledge is not only an academic endeavor, but a tribute to the human spirit. As a supervisor, I've been profoundly moved by the strength and courage displayed. You've been an inspiration to me. The pursuit of a PhD degree is not just about acquiring knowledge. It is about growing as a person, developing a unique perspective, and making a meaningful contribution to the world of academia. The skills you've cultivated, critical thinking, problem solving, and the ability to navigate the complexity of multiple disciplines will serve you well in your future endeavors. Whether you choose to continue with a career outside of academia, such as the one you recently started, come back to academia or take on leadership roles in various sectors, I am confident that you will make a lasting impact. As you move forward, I encourage you to stay curious, to remain a lifelong learner, and to use your expertise to address the pressing challenges facing our world. The journey doesn't end here. It transforms into a new chapter, one where you have the opportunity and responsibility to contribute to the betterment of society. I want to express my gratitude for allowing me to be a part of your academic journey. It has been a privilege and an inspiration to see your talent grow. Your graduation is also very special to me. I'm soon leaving Maastricht University, and you will be the last PhD graduate I supervised here, and a very remarkable graduate too. Such a nice way to end this chapter for me as well. I'm also very grateful to have been able to know you as a person. You have been a fantastic colleague and a great travel companion, putting up with the most uncomfortable traveling schedules, such as living in the middle of the night. And you have been the best source of suggestions for movies, books, and podcasts, and source of huge teddy bears. As you step into the next phase of your life, remember that the pursuit of knowledge is a lifelong endeavor, and your potential is limitless. May your future be filled with continued success, fulfillment, and the joy of making a difference in this world. Le ultime parole le rivolgo in italiano a te e le condivido anche con la tua famiglia. Congratulazioni Carlotta, sei stata una dottoranda eccezionale, hai affrontato ogni ostacolo ed opportunità con determinazione e curiosità, approfittando di ogni occasione per una tua crescita personale. Hai dimostrato di avere una grazia e forza d'animo infinita, nonostante momenti di stress e di dolore. Hai anche dimostrato un'eccezionale pazienza accettando ogni richiesta che ti ho fatto ed ogni proposto o suggerimento per un nuovo progetto o iniziativa. La tua famiglia non può che essere fiera di te e sono sicura che tuo papà lo sarebbe stato infinitamente. Ti auguro un futuro di opportunità e soddisfazioni. Thank you. Give back the floor.
Thank you, Dr. Ambrosino. Dr. Gamberini. It's so nice to see you emotional now, and I think it's well deserved on behalf of the whole academic community here. I would like to congratulate you with the degree you just acquired, and I extend that to the supervisory team, of course, and to the Institute of Public Health Genomics, and to the family, friends here, and maybe online. I was impressed because in terms of quality and quantity, of course, you know, this is real big work. You should be proud of that. I do have one addition to everything you've done today, because there's an extra take-home message, I think. I'm an emeritus in health promotion. So I think one take-home message is also the importance, of course, of health promotion, health education in universal antenatal care, and with an emphasis on empowerment. I think I should add this as a personal note. Before we came here, I talked to you just for 10 seconds or so, and I asked you about nerves. You said they're on the inside. Well, indeed, I did not see anything of nerves on the outside. So in the defense, I was really impressed by the fluency and the way you answered questions. We often see people beating about the bush, and here this was really to the point. So also, I would like to congratulate you with that.
Thank you.
And I wish you all success in your future career, taking up research in at least a position in a research hospital. So I guess that would be doing some research too. And of course, we encourage that because that's what the doctorate is about, isn't it? Thereby, I would like to close this session in a few moments. We will take a photograph with the new doctor in the hall, and I would ask you to, when we have left this room, to proceed to the reception area, which is to your right at the end of the hallway, and then we'll join you there later. And thereby, I indeed close this session.
Should I take this, right? I think I...
You can go first.